Good afternoon, everyone, and welcome. My name is Amanda Coventry-Barrage, and I'm DWDC's program coordinator. I'm joined today by my colleagues, Kelsey and Melissa. Today, I'm speaking to you from the traditional territory of many nations, including the Wendat, Haudenosaunee, Anishinaabe, and the Mississaugas of the Credit, located in Toronto and covered by Treaty 13. I acknowledge the legacy of colonialism and the impact it has had on all areas of life for Indigenous peoples, including healthcare. As part of DWDC's adherence to the values of inclusion and people-centeredness, we're committed to working towards recognizing, respecting, and addressing the distinct health needs of Métis, Inuit, First Nations, and Indigenous peoples related to end-of-life and medical assistance in dying. We will continue to work to listen to and amplify the voices of Indigenous communities in the discussions of end-of-life care. I am thrilled to welcome you today to our next session of Regional Spotlight, a series which aims to provide you with more information on how to successfully navigate MAID and your end-of-life care in every province. For today's session, we're going to be focusing on the province of Manitoba. And before I introduce today's presenters, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there will be opportunities to submit your questions. To do so, please type your questions into the question bar on the Zoom side panel, and we will read it out for you at the end. Please try to keep your questions as concise and clear as possible. While we are going to try to get to as many viewer questions as possible, unfortunately, we may not be able to get to your question. If you have outstanding questions following the webinar or questions that are quite personal in nature, please contact us at support@dyingwithdignity.ca, and we will follow up with you individually. We will also be sending a post-webinar survey that will pop up on your screen after the webinar. It will give you the opportunity to share your feedback, and please note that the session is also recorded, so you'll be able to watch it again later, and there's no need for you to take notes. Okay, now to introduce today's speakers. Originally, we did have Lindsay Bacala joining us for today, but due to unforeseen circumstances, she's not able to join us. So we will be having the lovely Audra Colasar, who's going to join us instead today. Audra has been a registered nurse for 20 years and has recently moved into managing the Manitoba MAID team since 1 year ago. Medical assistance in dying has been both a part of Audra's personal and professional life, and she finds her work in the assisted dying space both difficult and very rewarding. For our second speaker, we have Dr. Kim Wiebe here today with us. She's a practicing physician trained in internal medicine, critical care, addictions medicine, and palliative care. She currently serves as the medical director of the Manitoba Medical Assistance in Dying team. Wow, lots of qualifications from our speakers here, and I want to thank both of you for joining us today. I'm now going to pass it on to Melissa, who is going to get us started, as well as we have a lovely presentation from Audra and Dr. Wiebe.
Hi, yes, of course. Audra, you are welcome to start sharing your screen and begin your presentation.
I'm actually going to start.
Oh. Sorry, Kim.
So that's okay. I'll just pull this up here and make sure everybody can see it okay?
Yes, we can see it. Perfect.
Okay. All right, so I'm Kim Wiebe, and I'm the medical director of the assisted dying team in Manitoba. I've been involved since the inception of the team in early 2016. I was originally asked to be the critical care representative on a committee that was developing policy and procedure for assisted dying in Manitoba. At the second meeting, we received our first request for assisted dying, which was in early February of 2016. Manitoba had the second assisted death in Canada outside of Quebec. And the clinicians on the committee were asked if we would assist this first patient. Initially, most of us said no, indicating that we were happy to assist with developing policy and procedure, but we weren't prepared to be frontline providers. We all reassessed that and agreed to be involved with that first patient. I will say for myself, I sat back and thought about having an illness like ALS and being trapped in a body that was slowly shutting down around me, and thinking that I may someday want help to die, and that if I was possibly going to ask for it someday, then perhaps I had a duty to provide it to patients. I had a second conversation with myself about, trying it and seeing if it felt good or not good, and that if it didn't feel like good work for me, that I would stop doing it. And I will say that all of us, the initial group of clinicians that assisted that first patient, and then the second, and then the third, we all expressed that this is some of the most fulfilling and gratifying work that we have done in our careers. And I've continued to do it since that very first case back in February of 2016. So what are we talking about? We are talking about medical assistance in dying, commonly referred to as MAID, which is essentially the situation where a person seeks and obtains medical help to end their life. And I think it's important to emphasize that assisted dying can only occur if a patient asks for it. It's not something that would be done to a patient without them asking for it. In Canada, there are two types of assisted dying that have been legalized. Only one is really being practiced, but the law does allow for two types. My understanding is that Health Canada included both types in order to try to increase accessibility to assisted dying for Canadians. The two types of assisted dying were renamed a few years ago. Health Canada removed terminology referring to suicide and euthanasia because it is not considered suicide or euthanasia by the Government of Canada. So the one type is what Health Canada is currently referring to as self-administered medical assistance in dying. This was previously called assisted suicide. In self-administered medical assistance in dying, the patient administers the medication to themselves. It's typically oral medication, and typically the physician or nurse practitioner who has approved the request and written the prescription is not with the patient at the time that they swallow the medications. This type of assisted dying is the only type of assisted dying allowed in the United States. So when you hear about assisted dying in the United States, this is what they're talking about: oral medications that the patient gives themselves and the physician is not present with them at the time. The second type of assisted dying allowed in Canada is what Health Canada is currently calling clinician-assisted medical assistance in dying. This used to be referred to as voluntary or assisted euthanasia. In this form of assisted dying, the physician or nurse practitioner who has approved the patient's request and written the prescription also directly administers the medication to the patient. It's typically intravenous medication, and I hope somewhat obviously the physician is present with the patient at the time because they're giving the medications to the patient. This second type, IV medication that the physician or nurse practitioner administers to the patient, is the only option that we offer in Manitoba. We do have a plan for oral medication if a patient were to insist upon that, but the success rate with oral medication is lower than with intravenous. So we don't offer the oral medication. And that's very similar across Canada. Of the 30,000 or so assisted deaths that have occurred in Canada, less than 20 have been with oral medication. And in about half of those cases, the clinicians switched to IV because the patient didn't die with the oral medication. In terms of eligibility criteria, this is the same across Canada. And there's 5 main criteria, and that includes that patients have to be eligible for healthcare in Canada. And this was put into the law. My understanding is that it was put into the law to prevent people from other countries coming to Canada just to have assisted dying. You can be a recent immigrant or refugee and access assisted dying, provided you're in the waiting period, after which you'll be given a health card and a health number. The second criterion is that patients have to be adults, which the law defines as 18 years of age or older, and capable of making medical decisions for themselves. The third criterion is that patients have to have a grievous and irremediable medical condition, which has 3 criteria of its own that I'll show you on the next slide. The fourth criterion is that patients have to make a voluntary request that is not the result of any external pressure. In Manitoba, when we meet with patients, we always encourage them to have their family and friends with them, but we always make sure that during the meetings that we ask those family and friends to step out for part of the interview and make sure that we meet alone with the patients. And during the alone time is when we explore if they're experiencing any external pressure to proceed with assisted dying. The fifth criterion is that patients have to provide informed consent for an assisted death after being made aware of all options available to them, specifically including palliative care. So anybody in Manitoba or Canada who asks for help to die has to be made aware of the option of palliative care. They don't have to be enrolled or referred, but they do have to know what palliative care would look like for them. The stats in Manitoba and across Canada indicate that about 80% of patients are connected with palliative care at the time of their request for assisted dying. So grievous and irremediable medical condition. This is really where the majority of the decision-making occurs when determining if a patient is eligible or not. There's 3 criteria. Patients have to have all 3. And that includes having a serious and incurable illness, disease, or disability. The current law excludes mental illness, but that is going to change next year in 2023. The second criterion that makes up grievous and irremediable is that patients have to be in an advanced state of decline and capability that is irreversible. The state of decline can be due to the incurable condition or due to something altogether different. So the Canadian law is very interesting in that it allows patients to have multiple conditions that meet different parts of the criteria and add up to them qualifying. I should state that the incurable illness does not need to be terminal or fatal. It needs to be incurable, but it does not need to be a terminal condition, which again is quite unique. Most other jurisdictions that allow assisted dying require patients to have a terminal condition and be in the final 6 months of life. The Canadian law is much broader than most other jurisdictions. The third criteria that makes up grievous and irremediable is that patients have to have suffering that is intolerable to them and that cannot be relieved under conditions acceptable to them. The suffering has to be due to either the incurable condition or the state of decline in capability. It can't be due to something other than those 2 things. Currently, assisted dying is not allowed for minors. So you have to be 18 years of age or older to access assisted dying in Canada. It is also not allowed via advance directive or living will. You have to have the illness and be able to consent at the time that you ask for and are approved for assisted dying. So you can't set this up in advance for when you get an illness or when you lose the capacity to consent. That is not permitted in the current law. And then finally, at present, assisted dying is not allowed for mental illness as the sole medical condition. And the current law very clearly states that mental illness is not considered an illness, disease, or disability for the purposes of MAID. However, the current law includes what's called a sunset clause, indicating that as of March of 2023, mental illness will be eligible for assisted dying in Canada. In terms of how assisted dying works in Manitoba, we have a team that provides the service for the province. It's an interdisciplinary team that consists of physicians, nurses, social workers, administrative support, pharmacy support, and manager support with Audra. We also call in other professionals as required, including speech language pathologists, interpreters, spiritual health support, occasionally legal support and ethics support as well. We are a provincial service and we travel to wherever the patient is. We are set up as a team to do all parts of the MAID process that the law requires so that other healthcare providers don't have to be involved if they're not comfortable being involved. But we certainly welcome participation from any other healthcare provider involved with that patient. And patients and families are very appreciative when their other healthcare providers accompany them as they explore assisted dying. We will also support non-MAID physicians and nurse practitioners to do assessments and provisions for their patients if they wish, and they don't have to be part of the MAID team. We would work alongside them and support them to do the work if they and their patient desire that. In terms of the healthcare providers' roles when it comes to assisted dying, the federal law, provincial law, all of the college statements all very clearly state that no healthcare provider will ever be required to participate in assisted dying. However, all of the college statements, so the College of Physicians, College of Pharmacy, College of Nursing, etc., all of them go on to remind that healthcare providers that we all have professional responsibilities to our patients, regardless of our own personal beliefs. And with respect to assisted dying, healthcare providers are expected to respond to a patient's request. The healthcare provider can tell the patient that they're not properly informed or they're not comfortable fully discussing it and pass the request on to somebody who is, but they can't ignore a patient's request for information. As well, healthcare providers have to continue to take care of their patient. They can't abandon them because they've asked for assisted dying. They can, under certain circumstances, arrange transfer of care to another colleague, but they have to ensure that there's no gap in care. And as well, healthcare providers, specifically physicians in Manitoba, have to ensure that the patient has timely access to a resource that will provide accurate information. And physicians' offices also are required to share medical records with our team upon request. So what is the MAID process? So there's two different pathways that patients follow depending on whether their natural death is reasonably foreseeable or not. So the law outlines two different pathways. For patients whose natural death is reasonably foreseeable, so they have a condition that will cause their death, the pathway includes contacting our team, and that can be the patient or a family member on their behalf, or the healthcare provider that contacts our team, at which point an intake occurs, usually with one of our administrative assistants. Depending on the information provided at the intake, if the patient is eligible for further contact with our team, one of the nurses from the team will call the patient via phone to do triage and request medical records, which are also then reviewed by the nurse. That then is followed by 2 assessments, 2 independent reviews for eligibility, that the law requires that those be done by either a physician or a nurse practitioner. In Manitoba, we currently only have physicians that are doing this work. There's no nurse practitioners on the team at present. In Manitoba, the physician would go with a nurse or a social worker to meet with the patient to do those assessments. The assessments can be done in person or via Zoom or FaceTime or other kind of virtual modes. The law also requires, in addition to the 2 assessments, that patients complete a request in writing. If a patient is physically unable to write, then somebody can help complete the form on their behalf, but only under the actual kind of instructions by the patient. The law requires that patients complete the written request in front of a witness. There currently only needs to be one witness, and that witness can be a paid care provider. So a lot of patients will ask their palliative care nurse or their home care worker to be the witness for the written request. The next step is the actual assisted death, which we refer to as provision in Manitoba. And that encompasses everything that happens the day of death, which we'll talk about a little bit more. So the whole process takes quite a bit of time. It's definitely not an emergency service, not something that can be done quickly. It usually takes a minimum of 2 to 4 weeks, sometimes even longer than that, from when a patient contacts us to when they could have help to die. So it is very important that people know that it is not an emergency service. It takes several weeks. For the other group of patients, so patients who do not have a reasonably foreseeable death, the process that they have to complete is different. It includes all of those steps that we outlined on the previous slides. So intake, triage, 2 assessments, a written request. But in addition to all of those steps, the process in Manitoba includes a very detailed triage before meeting with the patient, including having the patient complete a questionnaire. That's a several-page questionnaire outlining their medical illness, their treatments, any services that they currently access, what they're able to do or not able to do for themselves, etc. And also a questionnaire that is sent to the patient's most responsible provider, so their physician or their nurse practitioner or their cancer doctor, etc. And so we go into quite a bit more detail with gathering a lot of information directly from the patient and their healthcare team before we go and meet with them. As well, we sometimes have the social workers from our team meet with the patient to do a psychosocial assessment. Again, this is often done prior to the physicians getting involved. The law requires a minimum 90-day assessment period for patients who are not dying from their incurable illness. And the law also requires that expertise input regarding the condition causing the suffering. So there has to be consultation with somebody that has expertise, essentially a specialist in the incurable condition. And finally, the law requires that the MAID doctors agree that the patient has given serious consideration to all treatment options available to them. And in Manitoba, we usually require patients to engage in an actual trial of treatment before we would consider their request for assisted dying. So what happens at the patient meetings? So as stated earlier, we do both in-person and virtual appointments, depending on where the patient's located. We usually have a minimum of 2 team members present, so always a physician, and then the physician can be accompanied by either a nurse or a social worker. Sometimes we'll have both a nurse and a social worker with the physician. We may also have other professionals, so speech language pathologists may be there if the patient needs communication support. We may also have spiritual health care providers present. Patients can also have their family or other loved ones, friends with them, and we certainly encourage that. We encourage all patients to have their support network with them at the time that we meet with them. Most appointments are for about an hour. We book 2 hours for provisions, but most don't take long. Occasionally, some will take longer than 2 hours, but on average, it's about 1 hour for assessments and 1 to 1.5 hours for provisions. We go to wherever the patient is. whether they're at home or in facility. Sometimes we'll meet them at an alternate location as well. And as stated earlier, we do travel throughout the province to provide this service. So what kind of questions do we ask patients when we meet with them? We will often start by asking them if they want help to die. We confirm that that's what we're there to talk about and confirm that they are in fact wanting help to die. There are certainly some patients that express a desire to die to their healthcare providers, but they are not necessarily wanting help to die. So it's certainly important to clarify with patients if they are getting ready to die and wanting a natural death, or are they in fact wanting help to die? We will also make sure that the patient is able to express understanding of their illness and how it is impacting their life and their ability to care for themselves. It's very important that we establish that the patient is able to understand their illness, the expected outcomes, the treatments available, etc. And then we'll ask patients to describe how they're suffering, why they want help to die, ask them to about alternatives and why they want or don't want to explore alternatives to assisted dying. And then we always ask patients if there's anything that would change their mind. And I will say that most patients answer that question by saying, yes, take away the cancer, take away the ALS, take away the heart failure. And most patients say, I don't want to die, but I am dying. And you can't change that, and I can't change that. And I want to have some control over when and how my death occurs. But I'd much rather be healthy and not be dying. We'll also explore with patients what timeline they have in mind and when they're thinking they would like help to die. We do try to focus our limited resources on patients that are wanting help to die in the near future. And so that is what we try to prioritize. As I said earlier, we always make sure to spend time alone with the patients. And during that alone time, we'll ask them if anybody is telling them or pressuring them to have an assisted death. We'll explore whether there's any financial pressures making them think that they should have help to die. We'll ask them if they have any concerns about their family, anybody that we should kind of look out for after they die, and ask them if there's any questions or any information that they want to share in private with us. We also, during the alone time, tell patients that when we come to help them die, we will meet alone with them for a couple of minutes that day as well. And during that alone time on the day of their assisted death, we'll ask them if they still want to go ahead. And if they don't, but they don't know how to tell their family that they've changed their mind, they can tell us in private, and we would tell everybody that we need to change the date. So we make sure patients know that they'll have a final out that nobody else needs to know about. And we share that with them during the alone time at the 2 assessments. We've only had 1 patient thus far take us up on that, but most patients are very relieved that they'll know that they have that final out, that opportunity. So the waiver of final consent, this is allowed now by the current law. It is for patients who have a reasonably foreseeable natural death and have been approved for MAID and have chosen a date for their assisted death. Those patients can then talk about completing a waiver of final consent. It's really intended for patients who may lose capacity to give that final consent on the day of their death. And it's a contract that the patient and the MAID provider enter into, whereby the patient says, I still want help to die, even if I can no longer give consent. And the MAID provider agrees to help the patient die, even if they're no longer able to give consent that the day of their death. There are several legal requirements for the waiver of final consent, including that a patient has to have been approved and deemed to have a reasonably foreseeable natural death. So it's only available for patients who have a terminal illness. As well, patients have to have chosen a date for their assisted death. They have to have been told that they're at risk of losing capacity to consent, and they have to complete a written agreement with the MAID provider. And they can only complete all of this while they still have capacity to consent. The waiver cannot be done by a family member after the patient's lost capacity. That is not allowed. Patients also have to understand that the law says that if I arrive to help you die and you're saying no, 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 or pushing me away or fighting me, even if you're confused and you don't understand what's going on, I cannot proceed if you show any signs of refusal. So what happens the day of death? The law requires that we give patients the chance to change their mind. So we have to do that, and we tell all patients that we're going to ask them a couple of times that day if they still wish to go ahead, and not because we're trying to talk them out of it, but the law requires that we give them the chance to change their mind right before they get the medications. We use 3 main intravenous medications, which we give over 5 to 10 minutes. A sedative called midazolam, followed by an anesthetic called propofol, followed by a muscle relaxant called rocuronium. And our prescription is very similar to other provinces and territories in Canada. I will say that the assisted deaths are by far the most peaceful and gentle deaths that I've seen in my 30-some years of medicine. Most patients lose consciousness in the first 1 to 2 minutes. So we do warn families that their loved one will become unconscious very quickly, within a minute or 2 of us starting the medications. A few minutes after the patient is unconscious, they stop breathing, and a few minutes after that, their heart stops. There is no incontinence, so patients do not lose control of their bladder or their bowel. A lot of patients worry about that, so we make sure to tell them ahead of time that that won't happen. And we also tell them there's no gasping, there's no moaning, there's no jerking or movement of the body. We tell patients that they can be dressed in whatever clothes they'd like. They can be sitting up in their favorite chair. They can be outside on their back deck. I often say to patients that as weird as it is to know the date and time that you're dying, it does allow you to make that time whatever you'd like it to be. And I would say about 1/3 of patients incorporate something unique for themselves, whether it's music or having people say a few words. Some will do kind of a photo video slideshow. Some will have a small celebration ahead of time. It really depends on how well they are or how tired they are. So now I'm going to hand it over to Audra.
Thanks, Kim. So just a little bit before I move into the misconceptions. So one of the questions we were asked is why we entered into this field of work, and Kim went through her exceptional story. For me, as a nurse, I worked with oncology patients, and for me, I had one of my favorite patients that I will always remember. We had a close connection. I had lots of dogs. He always asked me about my dogs every time I was his nurse. And once his treatments failed and he was dying, he asked me to kill him because he couldn't handle the suffering anymore. And at the time, that wasn't an option. And I told him, no, I can't. And, he looked at me and said, you treat your dogs better than you treat me. And that always resonated with me. And I watched him and was with him when he died, but just the loss of control and power. And it was a sad day. So that was a big motivator for me. And then in my personal life, I watched and cared for my grandfather during his dementia and saw him just turning into a person he never would have wanted to be. And again, this was pre-MAID legislation. And so it really motivated me to be there to support people in having choices and having some control over the end of their life. So that's a little bit about my story. So misconceptions about MAID. So Kim went over this a little bit, but MAID as an advance directive or an advance request. So anyone can make an advance directive. They don't have to have an illness. And it kind of sets out where they see themselves going in the future should they get sick and what they don't want to have. But as Kim said, MAID is very different. There's very specific criteria that need to be met before you can be considered eligible. Family members can make the choice for the patient. They can't. The person who has a diagnosed illness, disability, or disease has to be the person requesting. Mental illness as a sole condition, so that will change in 2023. Cost associated. So in Canada, this is considered a medical treatment and is covered by our healthcare. So there are no additional costs. Family. So as a healthcare professional, we are governed by the Personal Health Information Act, FHIA is also known as, and it restricts sharing of personal health information without consent of the patient. So if one of our patients tells us they do not want their family to be aware that this is the choice they're making, we are not able to tell their family, even if the family tries to contact us to ask. If the patient consents and wants their family to be involved, that's different. They've given their consent to share personal health information. However, what we do request of patients who are having assisted death is that somebody knows, because there's lots of logistical things that need to happen after a death. So we need to be able to tell someone so those logistical things can happen. And it would be their choice who that would be. Other misconception that their insurance or CPP are affected by MAID. So your life insurance and CPP are not affected. MAID is not considered suicide. So that's, Kim spoke to that at the beginning. That change in language has really helped with that misconception as well. So as an interdisciplinary team, our social workers play a big role in our work, and we provide grief support to patients as well as family members and loved ones that the patient has identified. So the social workers are there to support the patient as they go through their assessments and eligibility reviews. We do some psychosocial support specifically for patients, depending. We kind of went through that with the track 2 patients, those who do not have a reasonably foreseeable natural death. Depending on their situation, the social workers will help refer them to cancer care, palliative care, spiritual care, etc., for discussions around death and dying and end of life, depending on where the patient and the families are. After each assisted death, we will do a bereavement call with the identified family or friend just to check up on them, see how they're doing. We offer some grief counseling. We do have a limited amount that we can offer folks, so we can do a few sessions with them, but if their grief support needs go beyond that, we will refer them to another agency that can help them more in depth than we can. And we do have a grief support group for family and friends. It's a provincial program. It is virtual, so it's accessible for people who have access to the internet across Manitoba. And it's a chance for people to come together who've had similar experiences and talk about how MAID has impacted their life and the loss of their loved one. Thank you. So some of the feedback we get from family and patient supports is that they're really thankful they had time to talk through these important issues with the patient, to say goodbye, they knew what was coming so they could prepare themselves and have some discussions and say things that they wanted to make sure were said before the death. They enjoyed planning the day with their loved ones, being part of it. And as Kim said, there's sometimes there are special things that occur that are very unique to that family or to that person that they can be a part of. They have feelings of relief that that person isn't suffering anymore. as well as some guilt as well, that they weren't able to do to relieve that suffering or change that person's direction. Some folks have told us they feel a lack of support in the chores, so there is still some stigma in the community about MAID. So the families that we've talked to and have come forward, you know, are thankful that we're there to support them, but they do still find there's limited in the community depending on where their community is. Sometimes it's also difficult for them to deal with the patient not wanting others to know and respecting that decision that this person had made. So there's suffering kind of in silence, that they were able to do some pre-grieving, so before the death, and then through the support group connecting with others who've had the similar experience, and that especially around folks who the patient has said, I don't want anyone to know I had MAID. So this gives them that forum to talk to other people who have, you know, had similar experiences and can talk about some of the specific grieving around assisted death. So there are, we do talk a little bit about some gaps in service. So legislation doesn't actually require providers to offer bereavement support, and many provinces do not have these services. So in Manitoba, it's part of our priorities and our interdisciplinary approach to MAID. Families acknowledge that supporting their loved one through the MAID process was a rewarding but emotionally complicated experience, and there is a need for counseling and bereavement services. So that's just a quote from some research that has been done in this area. And the recurring theme of Manitoba families involved with MAID process is highlighting the desire to connect with others to explore experiences. So grief is similar, but there are some very specific nuances to a MAID death and the grief surrounding that. So there are additional supports for grief. So Bridge C14 is also a great resource that deals with MAID deaths. Canadian Virtual Hospice, so that's not specific to MAID, but it talks about death and processes leading up to death. Of course, Dying with Dignity, which I'm sure you're all aware of because that's the forum we're in right now. And then death doulas. So death doulas have a unique role. They come in for the death, but also have a lot of experience and training for families as well. So our experience as a team, we'll just go back one. So doing this work also has an impact on each of us. So we do experience grief, not necessarily from the loss, so the death of the patient, but the process and being a witness to the suffering and what we see. So as a team, we deal with this as part of our work. And there is also moral distress in terms of people requesting things that we cannot grant, people requesting MAID who don't meet the qualifications but really want to. Sorry, Kim, can you go back one? We talk about difficult cases as a team. We do debriefing with each other, and that helps us manage our personal feelings. Geographic and logistical complications, sometimes because we are the only, like we go out to everywhere in the province, sometimes that takes a lot of time and a lot of coordination trying to get to where everyone is. And just limitations of our program. So, you know, we all want the best in everything. However, there's always going to be some limitations to what resources we have access to. So forms, so just so people are aware, there are forms that actually need to be filled out. So the patient consent, the waiver of final consent, if it's appropriate for that situation. We have MAID information sheets that we give to families and friends, including the social work team has put together kind of the logistics about after death things they need to consider. So do you have a will? If you're renting an apartment, like just how to get your affairs in order. We will also send, for those who do not have a reasonably foreseeable natural death, a questionnaire to their most responsible provider and a MAID patient questionnaire as well, if that is appropriate. So just some stats to share. So this is as of June 30th of this year. So we've had over 3,000 contacts. We've received over 1,600 written requests and have assisted 975 deaths. We average about 3 to 5 deaths per week. We have also had over 1,000 patients die unassisted. So these are patients who have contacted us or have been involved in our process to some point and have died before completing that process with us. In Manitoba, we do have abstaining facilities. So these are facilities who have religious affiliations and do not permit assisted dying in their facilities. So we have to transfer patients from those facilities to another location for the day of their death. It could be another hospital, it could be their home. We've done assisted deaths in other locations, such as funeral homes and a church. So as we said, we go wherever the patient is, but there are restrictions in terms of abstaining facilities within Manitoba where we can do that. This is just a slide kind of comparing across the country where Manitoba sits in terms of total deaths. So this is ending of 2021. So Manitoba sits, kind of we're in like a little bit in the middle to the lower end. And you see that BC and Quebec have the highest rates. So we have, and it also shows that we have seen an increase in deaths, assisted deaths since the inception in 2016. Again, just a little bit of stats for you. So there's been over 31,000 assisted deaths as of December 2021 across Canada. It counts for 33.3% of all deaths. The average age is around 76 years old. 83% were 65 or older, and 95% were 56 years of age or older. And the split between male and female is pretty equal, with a little bit more male representation. So just some final kind of points. So MAID and palliative care are not, it's not one or the other. You can have both. And as Kim said, 80% of our patients have some involvement with palliative care. So that is, you don't have to choose between the two. You can benefit from both. At this time, people can self-refer, and there's no cost. And again, this doesn't impact people's life insurance or CPP, and does not require family involvement. We encourage it. We help support families who are challenged by these decisions and help them move through that, but it's not a requirement. And that's it for our formal presentation.
Should I stop sharing or?
Yes, you can if you'd like. Thank you so much for that great presentation. It's very informative, lots of great information for the viewers. And it's also, great to share, your experiences and what led you to working in this field. Because it is certainly, you talked a little bit about it, the MAID team experience, and it can be quite heavy at times, right? So it's great to have that support internally as well. So thank you for that great presentation. There are a few questions that we have. So either one of you are welcome to jump in and answer. So the first one is, this one is about death doula. So I know it was briefly mentioned, but for, viewers who are, death doulas or, interested in going through that field and working with MAID, in Manitoba, how does Manitoba work with end-of-life doulas, and any advice that you could give to death doulas to, get connected with the MAID team and how to begin that process?
So I can answer that. So that's something that we have just started to explore. So I met with a national, so I think they were actually out of Ontario, but just started that discussion to find out more about the work that they did. I really wasn't aware of it. So really good information. knowledgeable, and we're still trying to figure out how to make that pairing. But I definitely see the benefit for some patients to have a death doula on their path with them. We just have to figure out the logistics, but I'm happy if people are, a death doula and interested, they can contact me, and they can probably go through you, Kelsey, but to get there, yeah, no, I'm happy to have that conversation. I see that work as parallel, so.
Perfect. Kim, did you have anything to add? No? Okay, perfect. Another question that we had talks about people living with Alzheimer's, and what would the process look like for those who are living with Alzheimer's and want to die with dignity, and when should they start communication with MAID services? I know we discussed, capacity, but is there a best time for them to, begin the MAID process?
Well, you can really only have help to die for dementia when you're in that middle zone of dementia. So it has to be advanced enough that you meet the criteria of being in an advanced state of decline and capability, but still able to have the capacity to make medical decisions for yourself. So it's hard to say because it depends, it's unpredictable how quickly or slowly it's going to progress. And so we would tell patients to talk to their healthcare provider, and if they feel that they are in kind of the moderate range of dementia, then their healthcare provider can certainly reach out to us. What we have been doing in those situations is usually asking the primary care provider to do serial assessments with the patient, and then keep us updated, and then we would engage with the patient kind of when it gets kind of close to when they're going to lose capacity to consent. The concerns are that as dementia progresses, most patients lose insight into the fact that they're losing capacity. So unless patients are prepared to die earlier, while they still have capacity to consent, and potentially miss out on a year or two of life, then a lot of patients miss their window of opportunity to have MAID for dementia, because you have to have it while you still have capacity. You can't set it up in advance for when you lose capacity. Mm-hmm. So, yeah.
Perfect. Great. Yeah, I know so many supporters, and I'm sure you are so aware too, advance requests and people wanting to have that as an option. So it's certainly being looked at now. So we'll know more about that in
I will say though, as somebody who helps people die, mm-hmm. It's one thing to end somebody's life after I've spoken to them. I've heard directly from them how they're suffering. I know that they're aware of all of their options. It will be a completely different experience to help somebody die based on a piece of paper that they wrote years in advance. I've never met them. I've never talked to them. And I may walk in and they appear quite content in their nursing home. So I support MAID via advance directive, but I struggle with how that's actually going to play out as somebody who helps people die. So I could foresee potentially, if a patient had a family doctor that has known them for 30 years, has helped them write their advance directive, they've had multiple conversations, perhaps that healthcare provider might be comfortable saying, Audra and I have talked about this 100 times. I know this is exactly what Audra didn't want. I'm comfortable going ahead and helping her die. That's, one way I could see it happening. But to have somebody like me who's a stranger come in and proceed is going to be a lot trickier, I think. So, yeah. So I could see why, I totally get why the government is, holding off on that, because it's going to be very tricky to actually implement.
And it goes back to that whole idea of consent the day of your death, and even with the waiver, you have to be approved. So it's that autonomy and that choice piece that they have to reconcile how that's going to work, as Kim said.
Yeah. Perfect. Thank you. Another question that we got through through the Q&A was, how can we make MAID more normalized so it is not seen as negative? Because you did touch a little bit about, forced transfers is unfortunately a barrier for so many people. So it is still seen, as quite negative. So how can we make MAID more normalized so it is not seen as negative?
So that's a really good question, and I don't think we have the magic answer, but I think that and one of the questions that were sent to us in advance is the conversation around death. Has it changed in the past 5 to 10 years? And I would say it definitely has. Even before MAID became legal in Canada, I think with the, palliative care and having just opening up those end of life discussions has been a big movement. So I think that there is some change. MAID is a controversial issue. So there's bad press about it. And every once in a while, you'll hear a good story. And so, it's a difficult thing, but I think as people become more comfortable talking about end of life in general, I think there is room for me to come into that conversation, and people become aware of it. A lot of people still don't know about MAID, but they also feel more comfortable talking about it. So time, and I think will help. And I think just opening up more about talking about death in general, never mind, an assisted death. I think that's what needs to happen.
The European experience, I don't think the government of Canada was anticipating that MAID was going to become a specialty in Canada. I think the expectation was that a patient's primary healthcare provider would include MAID as part of their healthcare for that patient. So I think everybody was a bit surprised that it became kind of, there's less than 1,600 MAID providers in Canada. But the European experience is that after 10 years or so of assisted dying being legal, it switched from something that was provided by specialists to now in the Netherlands, the patient's family doctor is the provider for MAID. The second assessor is somebody with experience with assisted dying, so is a MAID specialist, but it's now part of family medicine care in the Netherlands. And I foresee that happening in Canada. When it was introduced, it was people like me who had trained, 10, 20 years ago that were asked to do it. I now give lectures to med schools, to all the residency programs. We're giving lectures to all the nursing students, social work students. So I foresee the next generation kind of coming into their careers with an expectation that this is just part of healthcare. And I think, over the next 5-10 years, I'm hopeful that we'll see the shift away from a specialty to something that's just part of primary care.
Mm-hmm. And that's so important, just so that everyone, can have the informed, choices, and being able to just get that from someone they trust, which could be their GP, right? So, and it's still so new in Canada as well, right? MAID has only been around since 2016, so there is still a lot that can change or evolve as we go on. But okay, great. Another question that we had was sorry, I'm just finding one here. So I guess this kind of ties in. Currently now, how does a healthcare provider get certified? They have quotations, certified to provide MAID. So are there any qualifications that are required to be a MAID assessor and provider?
Well, you have to be licensed to practice medicine, and you have to be involved in active clinical practice. So you have to have knowledge of the various illnesses and currently it varies by province. In Manitoba, we don't have a formal certification or training process. New team members that join do kind of a period of observing, whether they're connected with the other social workers, other nurses, other physicians. So they observe the work, and then they do some kind of work. They start doing the work with somebody there to support them until they feel comfortable kind of doing the work on their own. That said, Health Canada is in the process of developing a national curriculum for assisted dying, for MAID, that will be available, I think, in about a year and a half. And I could foresee at that point in time, most provinces and territories requiring practitioners to have completed that curriculum before they provide MAID. But the idea is that that as a family doctor, you can complete the curriculum on your own and then start providing MAID. But some provinces already have a training program that physicians have to go through before they can provide MAID. We don't in Manitoba, but we will probably once the national curriculum is up.
Yeah, it's more of an informal process. And we are exploring the nurse practitioner side of it as well. There's just different setups logistically between doctors and nurse practitioners that we're just trying to work through. But yeah, so hopefully that will advance soon.
Perfect, thank you. I just have a couple more questions. We are reaching the 4:15 mark. So this is from a social worker. How can I best support clients seeking MAID when their family does not want them to for religious reasons? Has this ever come across in your work?
Yes, so that is unfortunately common. And it's too bad Lindsay's not here because she is our social worker and she would be best to answer that question. But and it's a really difficult thing because that's moral distress on the patient's part, and as well as the family. There are some faiths that are supportive of MAID, so there's lots to work through there. To be honest, if someone is struggling, I would say reach out to the MAID team and see if we can support you. Our social workers are, often do that work, and we're here as a resource across the province. So yeah, that's probably, I don't want to give any advice because that's not my specialty, but it is something we come across often, and we help families move through that, and some families don't. It really depends on the situation, but our role is to support the patient and their family. So that's something we can offer.
Mm-hmm. Kim, did you have anything to add for that question?
I guess, like support the patient and let them know that you'll be there for them. And as Audra said, reach out to us. A lot of families, once they kind of understand how their loved one is suffering, I've often facilitated some of these conversations, and what I've found can be helpful for families is, and this is something that I learned from Dr. Mike Carlos, who was the former head of palliative care here in Winnipeg, is sometimes if you say to families, your loved one isn't choosing to live or die, because that choice has already been made. Their illness is terminal. They're going to die regardless of what any of us say or do. So they're not choosing between life or death, because that choice has been made and death is coming whether we like it or not. What they're choosing is how that death is going to look like. And sometimes I've actually been, impressed with how impactful that can be to families that are struggling with this, once they understand that it's not a choice between life and death. So that's just something that I can share from my experience of talking to families who are struggling to understand and support their loved one.
Mm-hmm.
And I think I would just add though, like in terms of because there was that religious piece to that question. So we do work with the spiritual care teams as well in the facilities, and they offer a lot of insight and support based on that aspect as well. They're a really good resource.
Oh, that's good. Kim, I was going to say that's a great perspective to put, looking at life and death, and that, it's death on how you want to choose to go. So I think that's a great perspective, because we do, hear so many from, people calling in, and that they are struggling with, family members, and that's important. It's something that's so important to them when they're navigating such a huge vulnerable time in their life and a choice that they're wanting to make. So yeah, so there's I have one more question that I wanted to ask, and this one's more for you, Kim, but you're Audra, you're certainly welcome to answer this as well, if you want. But Kim, so in your experience as a MAID provider, what are the last moments like when providing MAID? Are there any moments that, you know, stick out to you in your experience? What's it like for you when as a MAID provider in those moments?
Well, I'll maybe start by, you know, I'm often asked about how I do this work and about my need for self-care. And I will say that in all the different work that I've done over my career, I find I need the least amount of self-care doing this work. And I, having kind of sat with that and tried to figure out why that is, I've identified that it's 100% patient focused, which is rare in healthcare nowadays. It's 100% patient directed. You know, the patient is driving, the patient is controlling the whole experience. They have to ask for it. They get to decide if they want to choose a date. They can change their mind up until the end. So it's, you know, it's patient-centered, it's patient-directed. And then the patients that do go on to have an assisted death are very certain. And there's really no ambivalence that day of death. And they're so grateful and so appreciative. And they express that to us. And so that combination of factors really, I think, is what makes the work so gratifying and fulfilling, combined with being part of a team. I don't see that I could do this work and feel healthy if I wasn't part of a team, that I had to support me, and we support each other. We talk about cases, we're there with each other. In terms of actual experiences the day of death, you know, like life, it varies. Sometimes it's funny, and sometimes it's sad, and sometimes it's tense. But at the end of the day, there's always that last connection with the patient where they confirm that this is what they want, and you know, and they're just so grateful that is present every time. Whether the other environment is happy, sad, or tense, but yeah.
I think that's the most important thing too, is that they're so grateful, you know, to have this choice or to be able to, you know, support their loved one through it. So thank you so much for, you know, all the work that you do and involved with MAID. Audra, I know you, you know, if you want, in your work now involved with MAID, have there been any, you know, moments, or what has it been like for you to, you know, work with patients, or maybe, you know, if or families reach out afterwards? Have there been any, you know, moments in this work that I guess make you feel, or what led you to this space, I guess? Sorry, I was a little bit
That's okay. I think I know what you mean.
Yeah.
Well, it's been an interesting transition, right? And I think for me, as a manager, I take a back seat, right? So I don't do a lot of direct patient care, but I also am on the receiving end of families who contact us after to say thank you. And we always pass that along to our team because there's a lot of that. And sometimes it takes a minute after the death for families to really go through their processes and realize what has actually happened and their response. And that's when they choose to reach out to us to say, you know what, I was against it at the time, but I'm really glad that, you know, my person had peace, or, you know, so that's what I get to see. And it's rewarding work. It is challenging. Death is a very personal experience, obviously, but it's within a healthcare system. And that always kind of, you know, there's always that pull there because we're trying to fit it into a system that's defined, and it's hard to make it person-centered healthcare. But as Kim said, this is very patient-centered and patient-driven, and that is, it's a good part of healthcare to be a part of.
Mm-hmm. Perfect. Well, thank you so much for both of you taking time out of your day to do this webinar with us. And I know that there's so many people, today or they're going to watch this later, and it's really going to, help them navigate MAID in Manitoba, and just hearing from both of you and your experience. So thank you so much again. And just a quick reminder to those who are attending, there is a survey that will pop up after the webinar is done, and we appreciate all of your feedback about the webinar today. So once again, thank you everyone for joining us this afternoon, and have a wonderful evening and rest of your week.
Take care.
Thanks.
Thank you.